Okay, we're good to go. The previous talks actually set this one up very nicely. What I'm going to talk about now more are some of the scientific developments that can actually help mitigate the opioid epidemic. As we know, the opioid epidemic started from the use of opioids to treat pain. And underlying all this is a recent pandemic of pain. Chronic pain has been estimated to affect a third of the American population, which you can see is more than cancer, heart disease, or diabetes put together. But guess which 3 of these 4 diseases have their own institutes at the NIH? It's not pain. So the way pain has been treated for thousands of years, as has been alluded to before, is with opioids. Opioids were first mentioned by this fellow, Theophrastus, a Greek botanist who was studying opioid poppies about 300 BC. And opium extracts were used with great success until this fellow in the middle, Saturner, isolated morphine from the opium poppy extract in the early 1800s. As you can see from the fellow on the right, the use of opioids remains extremely popular in the present day. And these opioids, in spite of all the downsides we've heard, they're very effective in many cases of treatment, which is why they've stood the test of time. However, this comes at a high cost. Oftentimes they don't work. And you've heard a lot from the previous lectures about the problems with addiction. There's also the question of opiate tolerance. They stop working over time. Physical dependence, constipation, itching, and respiratory depression, which is a very serious problem. The list goes on and on. However, in spite of intensive research over the last 50 years, we've really found nothing better for the treatment of chronic severe pain. Now, the problem with opioids, as you see, has gone up tremendously. You can see that HIV, a concerted effort was made. And as Mark alluded to, we need to have a similar concerted effort with opioids. If you look here, the deaths of opioids are even more than gun control here. And it's shot up remarkably for many reasons, which we can discuss later in this decade. How did this all happen? Actually, it started back in the 80s and 90s when people began to be concerned about the treatment of chronic pain. There were studies that were stating that opioids that were used for acute surgical pain were actually safe for chronic use. Back when I was in medical school, there was really the worry about addiction overrode treatment of opioids with chronic pain. They were saved really for cancer patients or even hospice. I remember when I was a medical student, I was trained that if somebody came in with abdominal pain, you could never give them opioids because that would obscure the diagnosis of what's going on. I mentioned that to one of our surgical residents this weekend when I was on call, and they just laughed at me. Things have changed. The other thing that happened in the late 80s is that the long-acting morphine compound was coming off of patent. So other long-acting formulations of drugs were developed, such as OxyContin, which was introduced in 1995. Interestingly, this drug, given the political environment that Mark had alluded to, was approved by the FDA without any studies on the addictive potential of the drug. And the package insert at the time stated that this drug was safer with less addictive potential than other narcotics. And the punchline to this story is that the person at the FDA who worked and helped get this approval through then went to work for Purdue, the company that produced OxyContin. Then what happened? Well, there's all these drugs out there, and the problem is physicians were not trained in pain management. When I was in medical school, we had exactly 0 lectures on either pain or addiction treatment. How is this gap filled? Well, the only way it was filled out in practice was by drug company representatives who have a vested interest in seeing their drugs sold. There were also a number of studies that were funded by corporations that were making these drugs. A number of physicians were paid to go out and lecture about the safety and efficacy of these drugs, which I think started out well-intentioned, but then we got into the unintended consequences. There was also aggressive marketing of these to physicians. and aggressive lobbying of Congress to relax restrictions on these drugs. As has been pointed out previously, addiction is a disease, and it does alter reward pathways in the brain. The drugs, opiate drugs, cause positive reinforcement. They cause a rush. This is why they're abused. They also cause analgesia and work very well. However, the effects, these positive reinforcing effects, they fade over time, requiring dose escalation, which leads to all these other problems. Another component of the addictive process is drug withdrawal. The absence of drugs is unpleasant, and it's not life-threatening in the case of opioids. It is in the case of alcohol. And it can drive people to further drug use because this is a very aversive state. The loss of control or the craving or the propensity to relapse is really disastrous for people. People lose all sense of self and will do anything to obtain further drugs and basically sacrifice the rest of their life to do that. Now, we're going to be talking a bit about pharmacology during my talk, so I want to define the terms I'm using. So what I mean by tolerance is simply a decreased drug effect over time. If you give morphine or other opioids for pain, over time the analgesic effect will decrease. If you're shooting drugs for fun, the same things happen, and you keep escalating the dose. Physical dependence is simply an abnormal physiological state that's induced by the drug that requires you to continue receiving it to avoid a withdrawal syndrome, which is unpleasant. And this is not the same as addiction. An addiction involves more than just the unpleasant feelings. It involves uncontrollable drug use, a propensity to relapse, and basically a loss of control over the use of the drug. Now, when I was at MD Anderson, I used to say if addiction was the same as physical dependence, I would be really in trouble because almost every patient there was dependent on opioids, and I probably couldn't have made it from my office to the cafeteria without getting held up for my lunch money. But when you look at the causes of addiction, they all sort of flow together like this. What you see here is you have the rewarding or positive reinforcing properties of the drugs, which fade over time. And what you see then is that over time, the negative reinforcement or the relief of the aversive problems, the avoidance of withdrawal, becomes a more and more important component of addiction. Then you see that the abstinence and the craving for the drug and the propensity to relapse is another huge component. And these are all individual biological processes that can be dissected out, and I'm going to talk about that later in the talk. Now, there's a very important overlap, neurobiological overlap between pain and addiction, and this is why we end up getting in trouble. What you see here are the pain systems in red and blue here, and these are secondary pain processing areas. And when you look at the addictive areas of the brain, the areas that mediate positive reinforcement here in the amygdala, ventral striatum, bed nucleus of the stria terminalis, there's a lot of overlap here and a lot of crosstalk. And the green areas actually mediate some of the aversive properties of opioids, like withdrawal symptoms. And what you can see, other than it looks like a bad freeway map of Los Angeles, is that there's a lot of crosstalk between the circuitry of addiction and the circuitry of pain. And this actually makes a lot of sense, because pain is really a negative reinforcer. People do almost anything to avoid the continuation of chronic pain, which is good for survival. So one question I want to address right away is, why do people overdose? Well, the reason that people overdose is because not all drug tolerance is created equal. Tolerance to the different effects of opioids occur at different rates. So tolerance to the pain-relieving effects or to the rush occur much more quickly than the tolerance to respiratory depression. So you go from this state where people are partying on to this state where they're getting CPR and naloxone. And as patients escalate the dose, the risk of respiratory depression becomes greater because they don't develop tolerance to that. Now, I often treat a lot of pain patients, sedating them for procedures and so on. And I usually run around the hospital with a big syringe of fentanyl in one hand and a big syringe of naloxone in the other hand. And the patients often can't lay flat for a procedure or a scan. And I say, well, I'm going to give you this drug until one of two things happens. Either you stop complaining or stop breathing, whichever happens first. It's about a 50-50 proposition in a lot of these patients, and they will stop breathing, and everyone gets all upset. And I said, relax, they're going to be fine. You give them a little bit of naloxone, they come around. And the problem is it kind of reverses the pain relief as well. But the message here is that these are very dangerous drugs. These are not the sort of things you want to be doing at home. And that anything that can decrease the dose escalation for us is going to markedly decrease the risk of using these drugs. Okay. As Mark alluded to, there are a number of things we already know about these drugs that can help us in the use of them more safely and to avoiding the addictive potential. And I'm glad to see that here in Ohio, I think you are leading the way in implementing a lot of these strategies in terms of the prescription monitoring and usage of different drugs. But there's some very basic pharmacology that's been known for over 50 years that could help guide us in this direction. First, Vincent Dole in the 1960s and Mary Jean Creek at the Sloan Kettering Cancer Institute showed very conclusively that rapid increases in onset of blood levels in the brain and decreases of rapid decreases correlate with the addictive potential. The rush coming on much more quickly, the decrease in levels correlating with withdrawal and craving. What this means is that drugs with these properties, such as oxycodone, heroin, fentanyl, will be very addictive. And they make sense in the surgery or the post-surgical care of patients, but make no sense at all in terms of outpatient treatment of chronic pain. And these drugs, the old drugs that we use, morphine and Dilaudid, they tend to be better alternatives in the chronic situation. And my thought in this matter is that potent opioids used for surgery should not be used in general medicine. There should be no prescriptions out there in the community for fentanyl patches for low back pain. They should be used for cancer pain or hospice. Another simple solution, these potent drugs and the extended release formulations need to be reserved for cancer and palliative care at end of life. High doses of drugs, extended release or not, can addict people. Also, these pills can be hacked, and you can get then huge brain levels of these drugs. In fact, the initial formulation of OxyContin specifically said, please don't crush the tablets because you can get much more rapid release of the compound and possible overdose. So obviously, if you're an addict, it said crush here. And this formulation has been changed, luckily, recently. But there are other things that are better alternatives. In terms of long-acting pain treatment, methadone is really a great alternative. I see a lot of, what? Is it, are we getting echoing here? Okay. Well, I use it a lot in my patients perioperatively. We see a lot of opioid-addicted patients, and the use of methadone is actually perfect. You may have to use higher doses. It lasts for a longer period of time and mitigates withdrawal symptoms. The other point I would like to mention is that physician education is an extremely important part of this. And the state of Ohio obviously is taking great efforts here, but also I'm glad to report that medical schools are finally educating future physicians about pain management, addiction, substance abuse in response to the opioid epidemic. And these are very encouraging developments. However, it's going to be 10 to 15 years before we see the fruits of these efforts. So we need to still be diligent in terms of our education of existing physicians and putting a lot of these educational efforts or mandating them as they are in Pennsylvania in terms of your CME requirements. So I've told you about old data that can help us to more safely use opioids. There are also a number of new developments on the horizon that help us to understand opioids better and to use them more safely. I think one of the interesting things that Mark talked about was our attack on things like HIV, ischemic heart disease, and understanding those. And I think to have a focused effort like that, you really need to understand the basic mechanisms underlying the disease. And I think in the case of HIV, that's very clear. We have a viral etiology. We know a lot about how it works. And then we have sort of like an action plan, or almost a moonshot, if you will, to eliminate the disease. And as you saw, the mortality of AIDS has gone way down. An example of where this strategy hasn't worked is cancer, where not a lot is known about the underlying disease. It's too diverse. And so it's really not yet time, I don't think, to have this big grand strategy. In the case of opioids, we are getting closer to that time, and I'm going to describe my journey to understanding better the mechanisms of opioid tolerance and how you can dissociate those from the rush or from the pain-relieving effects of opioids, and how we can use that to use opioids more safely in practice. So this got started many years ago when I was asked to speak to some of our fellows about the anesthetic implications of chemotherapeutic drugs, which I thought was a complete waste of time. And in general, it was. But there was a very interesting thought I had while I was looking at some of these drugs. At the time, one of the first chemotherapeutic agents for personalized cancer therapy came out. It was called Imatinib, or Gleevec. It's used to treat leukemia. And this drug is a platelet-derived growth factor receptor inhibitor. And I noted that this receptor is a receptor tyrosine kinase. And I knew that receptor tyrosine kinases can be activated by G-protein coupled receptors. And it turns out that the mu-opioid receptor, where narcotics work, is a G-protein coupled receptor. And well, this is very interesting, but why should we look further at that? So I investigated a little further and saw that this receptor was localized specifically in the nervous system to pain processing areas. We see here is the spinal cord of a rat, and what this area that's lighting up with platelet-derived growth factor receptor is called the substantia gelatinosa in the dorsal horn of the spinal cord. And this is selectively where all the pain-sensing peripheral neurons synapse here, and this is also very heavily expressing mu-opioid receptors. And you can see it's really nowhere else in the spinal cord. This friend of ours here on the right is the dorsal root ganglion, which are the nerve cells for these sensory neurons that live near the spinal cord and go out to the periphery and then come in here to synapse. And it's jam-packed with platelet-derived growth factor receptor. The distribution of this receptor is really restricted in the rest of the nervous system, and I said this is too much of a coincidence for it not to have a role in pain processing, so there had to be a reason for this. So the first thing I did was try to figure out if morphine actually activated the platelet-derived growth factor receptor. So what we did is created a cell line using a glioblastoma model where we stably transfected the mu-opioid receptor into this. And we treated these cells with morphine and Gleevec, and we immunoprecipitated out the platelet-derived growth factor receptor, and then did Western blotting on it to look at both total amount and to look to see if it was activated by looking at phosphotyrosine residues. And what we found is that morphine pretty strongly activated the platelet-derived growth factor receptor beta isoform in the spinal cord. This was blocked by Imatinib. It was also blocked by naloxone, which meant it was an opioid-mediated mechanism. Now, this is very nice, but I've done biochemical studies before. They don't always correlate with a behavioral response. So I wanted to see a response in animals. And I wanted to see a response in animals that were being treated similarly to some of our patients. So we're talking megadoses of opioids. So what we did is took some rats and did dose response curves, which is basically giving them escalating doses of narcotics from low to high and seeing what their dose response profile was. Then I implanted these rats with as much morphine as I could without killing them. And what this turned out to be is 2 extended release 75 milligram tablets of morphine. So 150 milligrams of morphine, which is a lot, as you might guess, a lot for a human, a lot for a rat. As one of my British colleagues put it, it was a sporting dose. And we let these animals just sit for a week or two, for about a week. And then what we did is we did the dose response curves again, and I'll show you that here. So here's what we started with. And we use a test called the tail flick latency, is where you shine a hot light on the tail of the rat, and the pain relief generated by the drug is demonstrated by how long the latency is, and it increases. So you see we have baselines here. Actually, they're about 3 to 4 seconds. This is showing us at a dose of 2 milligrams per kilogram of morphine, we get a very slight pain relieving response. And this goes up as we go from 2, 4, 8, 16. We have a 10-second cutoff so we don't damage the tail. You can see all of our groups initially were the same. We implanted the pellets, and then we went about a week later and looked. And what we see is that the morphine implanted animals develop a big dose response shift. This is the normal, the placebo animals again. It looks just about the same. They've developed about a 10-fold shift in the dose response curve. And you can see by pretreatment with Imatinib, 30 minutes before we started the dose response, we almost completely eliminated tolerance. And if we did the same thing the next day, and it was completely eliminated. And this is a very good effect. We did it in a wide range of doses and different routes of administration. We then wanted to look and see if this would have the same effect in primates, which are much closer to a human model. So what we have here is studies done in monkeys, where actually monkeys, we use their tail, and it's actually dipped into a bath of hot water, and these are the baseline responses. And what we see is when we give the monkeys morphine IV, tolerance does develop over time. And then when you switch that and just give them Imatinib, they immediately come back to baseline and stay there, and will keep going at that level indefinitely. And the same thing happens in reverse. If you have animals and give them Imatinib, they won't develop tolerance, and then you take it away and they immediately are tolerant. So one question we wanted to ask is how do opioids actually activate the platelet-derived growth factor receptor? There are two main ways that they can be activated. One is called transactivation, where you see that the signaling molecules inside the cell from the G-protein coupled receptors directly link to the growth factor receptor. In this case, I have it says EGF, that also does that. It's just the best figure I could find. So they're related to the PDGF. So you can have it directly act transactivating. The other thing that can happen is you can have the release of ligands from the extracellular matrix or from intracellular sources, and you can have it activate the receptor that way. So what we found is that the peak activation of the PDGFR by morphine took place at about 40 minutes. And this is usually, if you have transactivation, it's much faster. The other thing is that pharmacologic antagonists are not entirely selective. So we wanted to establish this selectivity for the PDGFR-beta. So what we did, it would have been nice just to have a monoclonal antibody, which didn't exist at the time we were doing these experiments. So what we did is constructed a scavenger molecule by using the extracellular domains of the platelet-derived growth factor receptor and fusing them to the Fc domain of the antibody molecule, which renders them soluble. So they go around like little Pac-Men and gobble up if there's any released platelet-derived growth factor receptor. And we found the following results. So here's our little scavenger molecule, a little reminder of that. And here we have the tail flick latency, and these are the normal baselines we see. And what you see here is that the initial dose of morphine that we gave caused an acute analgesic effect, and then tolerance developed rather quickly. Okay? And what we see here is that the scavenger molecule actually completely eliminated tolerance until day 4. And on day 5, we reversed the treatments. In these cases, these control treatments received morphine and had a full analgesic response, either with the vehicle or the scavenger alone. But interestingly, the ones that were treated with the scavenger, when you take away the scavenger, they were tolerant. So you basically just masked this development of tolerance. You haven't blocked the underlying mechanisms that cause tolerance. And this was actually a good thing, we thought, because drugs that do block the underlying mechanisms of tolerance tend to be very neurotoxic. Their NMDA receptor antagonists are a good example. Things like ketamine, PCP that turn your brain into Swiss cheese. So we thought this might be better and a little less toxic in terms of treating these people. So what we've shown here by these experiments is that to see tolerance, that you have to have activation of the PDGFR. So it shows it's necessary, but is it really sufficient to induce tolerance? And the way to look at that is to treat animals with the growth factor itself and then see if morphine works after you treat them with it. And this is a very busy slide, but I'll walk you through it. And what we see is that if you treat animals with the growth factor or with Imatinib, you don't alter the analgesic effect of the drug. This, again, like the other slides, indicates that none of these drugs really alter the analgesic properties of the drug. And what you see is that Imatinib blocks morphine tolerance, which is fine. And then you see that tolerance develops at the same rate, no matter whether you give the growth factor. We have a number of groups. We give growth factor, and morphine. The combination of all three, you get the same tolerance curve. So what we did here is a little different. What we did is, for all of these animals that were treated with morphine, we just continued the same treatment. So the Imatinib group still inhibited tolerance. In this case, these animals either had been pretreated with just vehicle or with the growth factor. And to these groups, we gave morphine. And we see that the vehicle did not affect the analgesic properties of morphine. In this case, what you see is, though, that pretreatment with PDGF growth factor, BB, induced tolerance. Morphine didn't work as subsequent to that. So not only is PDGF activation necessary to cause tolerance, it is sufficient to cause it as well. The other question that was of interest to us is receptor internalization required for the development of tolerance. In classical pharmacology, which we were taught in medical school, tolerance is thought to be due to desensitization of receptors and then their internalization. We actually have shown that this is not the case, okay? And what we did is we did some very simple studies, as we'll show you again. We gave animals either combinations of morphine plus Imatinib alone, or a synthetic opioid called Damgo, which is a peptide actually, which is very potent. Damgo is known to internalize the mu receptor very strongly, so we use that as a positive control. Morphine generally does not internalize the mu receptor. And what we showed here is that while morphine and Imatinib block tolerance, which we see here, when we look down here and look at the internalization of the receptor, we really see no change. So tolerance occurs independently of internalization in this case, and here you see the Damgo positive control. Now, drugs like fentanyl do cause internalization of the receptor, and what we do see again is we can block, and this is data that is just brand new, we can block the development of tolerance to fentanyl, but it still internalizes, and we're preparing this for publication. So we've extended these findings, as it were. So what I've shown you in summary is that the PDGFR-beta signaling is necessary and sufficient to cause opioid tolerance. And it's very specific and selective. I didn't show you all the data underlying that. The reason this was such a big deal is this is our first demonstration of that you could completely dissociate an undesirable side effect of opioids from the pain-relieving properties. So a complete dissociation of tolerance from analgesia, and others have gone on to show separate mechanisms for dissociating physical dependence from analgesia. And this suggests that it's not all about the mu-opioid receptor in terms of tolerance, that it's initiated by non-mu-opioid receptor-mediated events and occurs independently of the recycling or internalization of the receptor. Here's a cartoon of the mechanism, and what we see here is basically that the opioid binds to the mu receptor and causes the release of platelet-derived growth factor, either from extracellular points or from intracellular stores. We haven't completely identified where that's coming from yet. It comes and activates the platelet-derived growth factor receptor, which is blocked here by Imatinib. This leads to effects on analgesic effectors that still have not been characterized, but we're working on that. and leads to the phenomenon of tolerance. And this has been a very radical proposal for the pharmacologic community. And why is that? I think, as I alluded to before, the classical view of tolerance was that opioid would bind here, you would have desensitization, then you would have downregulation, internalization of the receptor, and that led to tolerance because you had less receptor floating around. Now, there was a lot of data contradicting this, and one specific problem was something I call the morphine paradox, whereas morphine can induce profound tolerance, but was shown in vivo not to cause internalization. So another hypothesis was proposed, that's not it, which is this one, that sustained signaling rather than decreases in signaling led to tolerance. And what they show here is our friend Damgo, that would have rapid degradation, no signaling, and that morphine had sustained signaling because it didn't cause internalization. What my results suggest is that both of these things are probably epiphenomena or red herrings and not really relevant to core mechanisms of tolerance, and people really didn't like that too much. However, they've come to accept this theory over time. It's gaining more and more traction, and studies are continuing to confirm our findings. So, talking to you a lot about opioid tolerance. Well, what about pain? This is sort of what I do for a living, and we need to come full circle. I think this is really the key problem. This is what got us into this mess in the first place. When I started out trying to do research, pain and tolerance were thought to share mechanisms. And I thought it would be much easier to study tolerance because the opioid receptor was known and pain seemed a little daunting and complex. And I would say pain is still daunting and complex. But if you think about it broadly, you could characterize pain into two broad types, which are inflammatory and neuropathic due to nerve injury. Now, opioids work very well against inflammatory pain, at least acutely, and don't work very well against neuropathic pain. So, as is usual for me, I took the easy road. I started with where opioids worked and looked to see what happened when using morphine and imatinib on a model of inflammatory pain. And the model of inflammatory pain we use is injection of complete Freud's adjuvant into the hind paw, and it causes an inflammatory swelling that lasts about 2 or 3 weeks. And what we saw in this model, it's slightly different than the tail flick. You have a paw withdrawal latency. You shine the same hot light on the paw, and we set the latency higher, so the baseline's between 10 and 15 seconds. After you inject the CFA, they get what I call a hot foot, and they are very much more sensitive to thermal pain. We see we bring our latency down to about 3 seconds at baseline. And what we see here is we give a modest dose of morphine, and tolerance develops pretty rapidly to its effect. And what you see is when you give imatinib, it's Gleevec here, we see what we would have expected. We block the tolerance, and it just keeps on going. So that's good news. It's exactly what we would have expected to see based on our findings before. Now I had to turn my attention to the tough problem, which is the issue of neuropathic pain, which we see in cancer, we see it in a lot of injuries, acute injuries, phantom limb pain, a lot of war injuries. So we used a model of nerve injury pain called sciatic nerve ligation, and what you do is you expose the L5 nerve root of a rat, and you tie a stitch around it and tie it very tightly. And this causes a very prominent mechanical sensitization in the rats. So they're very, very sensitive to touch, almost like a sunburn. And this is a very prominent symptom of neuropathic pain, and one that's extremely hard to treat with opioids especially. So we used this model. We did the surgery on the animals, allowed them to recover. And then we did the same exact experimental structure as before. Oh, the results we got completely blew us away. And what we did is you test them for mechanical sensitization by poking their feet with little filaments of varying strengths and seeing where they respond. Normally, we have a baseline pressure of 15 grams. The filaments bend, and this is a very stiff filament. Normally, the animals don't respond at all, so they're at baseline here. What we see is that after the surgery, they get a very profound hypersensitivity. They respond to very low strength filaments by withdrawing their paws. And if you give the same dose of morphine that we used before in mechanical stimulation, nothing happens. Imatinib alone, nothing happens. You put the two together and you have complete pain relief. And this just keeps on going. We've tested this out as far as 3 and 4 weeks, and it just keeps on going. And we never saw anything like this before, and it's kind of the opposite of what I was saying. I was saying that this drug actually it just it targets tolerance, not pain relief. And this looks like a synergistic effect, doesn't it? And so I was puzzled by this and had to think about it for a time. And I came up with I kind of reframed the question over time. What we see here is that the morphine is less effective than it was in the inflammatory pain condition. If the same dose is less effective, could this be something like a tolerance situation where the animals are already tolerant? And why would they be tolerant? Well, in the good old days, they used to call these chronic neuropathic pain syndromes reflex sympathetic dystrophy or causalgia. And what was thought to underlie this syndrome was the development of new synapses that formed and went and had abnormal connections to the sympathetic nervous system, et cetera, et cetera. At the time, when I started doing these experiments, no one knew what caused these sprouting and abnormal connections to start. And now we do know, and what does cause this to happen is growth factors. So you can probably see where I'm headed with this experiment. So basically, it seemed to me that these injured nerves could be secreting PDGF. That was the hypothesis. And that would render the animals tolerant to morphine. So what we did is we got our scavenger molecule back again and did the same experiment, ligated the sciatic nerve, got a profound mechanical hypersensitivity, and reversed it with the scavenger, proving that injured nerves release these growth factors, which render the animals pre-tolerant, if you will, to opioids, so they won't work well when they're used. Even if they wanted to, you'd have to markedly escalate the dose because they're already tolerant. And this is the phenomena, that, sort of a cartoon of that. What you see is that nerve injury causes the release of the growth factor, activating that, creating the tolerant condition without activating the mu receptor. And as you see in the case of morphine, you get the same response just from activating that. So here's also is our demonstration of the mechanistic link between tolerance and chronic pain that people had postulated for many years. So will this work in patients? There have been a number of case reports coming out using the EGFR, which is closely related in cancer patients, and also in sickle cell patients, which I've taken care of a lot of them over time. It turns out that now they're doing better, growing into adulthood and developing cancer. They're developing leukemia, which is treated by Imatinib, and there have been several case reports of the pain crises of these now adults being completely eliminated by Imatinib. And we're currently working on a multi-center study to study these patients and see if Imatinib actually does, in a controlled fashion, relieve these symptoms. The other thing to note is that Imatinib is used to treat chronic myelogenous leukemia, the Philadelphia chromosome variant. So people are required to take this drug daily for the rest of their lives. And what we've seen is over time is that the Imatinib is very well tolerated, about 95% 5-year tolerability. And the doses we're talking about using, if they translate from the rat and primate to the human, will be about 10-fold less. So there should be very little toxicity involved. So I'm presenting again our model of addiction. As you can see, there are 3 main components we talked about. We talked about tolerance leading to a decrease in reward, physical dependence leading to a negative affective state that needs to be reduced, and then the whole problem of addiction and craving. Tolerance really is only one of these components. However, even if we can only prevent escalation of drug dose using Imatinib or this strategy, it's a major win because we can, 1, reduce doses in patients that are already very tolerant, and we can also prevent dose escalation in patients that are newly put on opioids. And this could prevent the progression to dependence and addiction. And that could turn out to be a blockbuster in terms of helping us fight the opioid epidemic. This is the team that's worked with me on studying all these problems and generated all this data. And we do have many more problems to solve, and hopefully some of you will be able to help us as we go forward, as we begin our translational studies, moving these out into the clinic. And I want to leave you with one parting thought, expanding on what Mark said, but from our good friends, the Russians. If you wake up and you know you're not in pain, you know you're dead. And yes, pain is a part of life. But unfortunately, many of the patients I see are the living embodiment of this quote. And my hope through all the research I've done has been that the unrelenting, uncontrollable pain that many people experience will become a thing of the past, and we'll finally be able to do what has been the goal of all physicians throughout time, which has been very elusive, is to eliminate pain and suffering for all our patients without inducing the pain and suffering caused by addiction. Well, thank you very much.
I think we have time for a question or two if anyone has any burning ones. Okay, if not, there's one. Go ahead.
Okay.
Just wondering if you have any thoughts about, you had mentioned that tolerance is one of the downsides of, abuse of opiates. I guess, trying to think of how to word this. I was listening to the radio the other day, and somebody had claimed to come up with a cure for hangovers, and then somebody else said, well, maybe hangovers are good because they will help you not use, not abuse alcohol because you have that, the bad thing that happens afterwards, right? Consequence. Do you have any thoughts about what being able to eliminate tolerance would have for, would that inspire, help people abuse opiates long? I mean, obviously, it's a huge issue, so it's not like, it's not a problem.
I think they would actually abuse less, quite frankly, because you need to hit a certain. It seems that you need to hit certain brain levels and rapid, in a rapid fashion to trigger the switch from just casual use of opioids to addiction. And if you start people on these drugs and they use lower doses and get effective pain relief, I think you avoid that. Now, if people are just taking them for fun and games, they could also use lower doses and use more safely. Whether that, in fact, I think that eliminating hangovers, one, has proved to be elusive, and I think Howard Edenberg will tell you that it really doesn't have much of an impact on addiction because the negative reinforcing properties of withdrawal are just so strong in either case that I think you'll still see a fair amount of addiction. But we still need more data.